tutorial USMLE course on nephrology.
Okay, so after the acid base, I will go on to the potassium metabolism, which is one of the most common potassium and sodium metabolism. So you will see this on your exam for certain. Regulation of potassium homeostasis. Potassium mainly is in the cells. You see the amount here. And importance of cell shift, that's regulated by certain hormones like beta stimulation, and in the ECF, meaning in the blood and outside the cells, there's much smaller amount. Then it goes into excretion through the kidney and the GI tract. Factor that influence the internal distribution of potassium, meaning internal, meaning cell shift. Like I said, it's hormone related, and this is one of the most important parts of the potassium homeostasis. Insulin, beta-2 stimulation, metabolic alkalosis make the cell shift. Potassium is going to the cell, so serum potassium would go down. Mineral acidosis, meaning hydrochloric acid and so forth. Increase serum tonicity like hyperglycemia. Beta blocker, alpha stimulation increase the cell shift out of potassium into the ECF, so increase serum potassium. Very important concept. Okay, again, cortical collecting duct, principal cells. This is the key regulation of serum potassium because of the potassium excretion occurs here. This is a luminal border, this is interstitium, this is principal cell. You see the sodium potassium exchange and the sodium potassium ATPase, which use ATP here at the interstitium. And this is influenced by hormones, aldosterone. Mineralocorticoid activity and distal delivery of sodium, which I will show you later, and the urine flow rate. Okay, again, distal delivery of sodium from the proximal part down to the distal tubules. It influences how the potassium and sodium exchange here. Potassium comes out by the negative charge here. So when you have lots of sodium come down here, then you would drive this exchange. Sodium goes into the cell, potassium comes out. Interstitium also, aldosterone acts here. So it stimulates this pump and end up losing potassium in the urine. Okay, important concept again, relationship between distal sodium delivery and aldosterone. When the patient has hypovolemia, meaning the effective arterial blood volume is decreased, then you would have decreased distal sodium delivery because of the increased proximal sodium reabsorption at the proximal tubules. Okay, you would increase aldosterone excretion. Then in the hypervolemia, meaning increased effective arterial blood volume for whatever reason, then you would increase the distal sodium delivery because the volume is already high. So the kidney responds to try to excrete more sodium, so then you reduce the proximal reabsorption and it comes down distally, and you would inhibit aldosterone. So you would see the distal sodium delivery and aldosterone go opposite way. So you won't lose potassium. And just to show you the intestinal secretion, you see the potassium component in the colon is very high. Bicarbonate is also high in the small bowel and the colon. So when you have diarrhea, for example, then you will lose a lot of potassium and bicarbonate. Okay, one example, laxative abuse. Patients who take lots of laxatives, then they will develop metabolic alkalosis, okay? Not metabolic acidosis like what you think. Diarrhea mainly cause metabolic acidosis, but chronic laxatives abuse cause metabolic alkalosis because they lose a lot of potassium, and then it increased ammonium production and increase of the ammonium chloride here. So, okay, down to next to increase aldosterone activity, you will see the primary increased aldosterone in, let's say, Con syndrome, adrenal tumor that release aldosterone. So primary increase in aldosterone, what happened? You would have high volume, increase distal sodium delivery into the distal tubule. Then aldosterone acts at the pump and the sodium potassium exchange, then you would end up losing both sodium and potassium in the urine. So hypokalemia, metabolic alkalosis. Again, I will show you renal potassium wasting because you have increased aldosterone and increased distal sodium delivery. The earlier slides, potassium is conserved when this doesn't go together. When the aldosterone and the distal sodium delivery goes together, then you will lose potassium. Okay, primary hyperaldosteronism, again, elevated aldosterone because of the primary increased production, renin's depressed, is a feedback mechanism. Con syndrome, bilateral adrenal cortical hyperplasia, there's many other diseases, and end up losing potassium. So again, patient with the primary increase in distal sodium delivery, primary increase in the sodium delivery because of the diuretics. We give Lasix or other syndrome that mimic the Lasix. Then Lasix inhibit the sodium potassium through chloride exchange at the thick ascending limb. Then sodium would go down distally. Then because of the hypovolemia, right, from diuretics, you lose sodium and then cause low blood volume. Then mechanism of the body would raise the renin and aldosterone. So again, a couple of the sodium delivery that's high plus aldosterone that's high, then you end up losing potassium. So hypokalemia. But primary is because of the diuretics, but this time is low volume. The syndrome on the list earlier, it caused the hyperaldosterone. This is interesting syndrome. Syndrome of apparent mineralocorticoid excess, deficiency of this enzyme. 11 beta hydroxy steroid dehydrogenase, either acquired or genetic. This enzyme, what it does is usually it inactivates the cortisol. There's a cortisol receptor in those cells, and this enzyme normally activates the cortisol. Because cortisol has, it acts at the mineralocorticoid receptor as well, but it has a lot of cortisol compared to the aldosterone. Even though it has less affinity to the receptor, but because of the huge concentration, then it has impact on the receptor if there is no or not enough of this enzyme around. So the enzyme deficiency would allow the cortisol to activate the receptor, which normally would not happen if you have enough enzyme, okay? So what happened is you see the syndrome of hyperaldosteronism. Okay, hypokalemia. How you would investigate? You would need to see whether the potassium is lost in the urine or not. So the urine potassium is the key. If the urine potassium is low, meaning that the kidney acts appropriately in order to conserve the potassium, less than 20 MEq per day is appropriate because you don't want to lose potassium. If the kidney is normal, then it would do its jobs, and then the diarrhea you have to lose through the GI tract. Okay, if it's more than 20 MEq per day, then you would see whether the blood pressure is high or low. If the blood pressure is high, okay, then you think about aldosterone because it's high volume, high renin, and goes down this path. If the blood pressure is low, the volume is low, then you think about diuretics and vomiting, for example, and you would differentiate this using the urine chloride. So when you see the patient with hypokalemia, you should check the urine electrolytes, especially potassium and chloride, and look the blood pressure, whether the patient has low indication of low volume status or high volume status, and the history would give you the differential diagnosis. Okay, thick ascending limb of Henle's loop diuretic acts here at this transport. Sodium to chloride potassium transporter. And this is again sodium potassium pump at the interstitium. This is luminal border. These are loop diuretics. Bartter syndrome mimics the loop diuretic action, everything, but it is genetic defect here. So you will see hypokalemia, metabolic alkalosis. Primary increase, again, in distal sodium delivery. This time is thiazide diuretics. You know, hydrochlorothiazide. It acts at the distal convoluted tubules, different sites, cause low blood volume, the same because it makes the body lose sodium, therefore, and also lose potassium because low blood volume would stimulate aldosterone release. So again, you see distal sodium delivery that's increased along with high aldosterone, then you would lose sodium and potassium in the urine. This time because of the thiazide diuretics. And there's another genetic disease called Gilderman syndrome, X defect, same site as the thiazide receptor. So you will see the same effect. Distal convoluted tubule. This is part of the acidosis. Distal convoluted tubule. Sodium chloride exchange. This is the sodium potassium and sodium calcium exchange at the interstitium. And you see the calcium here. So this is the thiazide diuretics action here. So it inhibits this pump, so then you would lose sodium, lose potassium, and you would increase the blood calcium through this pump. So again, Bartter is Lasix, Gitterman is thiazide. Okay, so you see low potassium in the plasma, high, meaning hypokalemia, metabolic alkalosis, right? Urine calcium, they're different because of the action of the syndrome at the sites of the different sites. Calcium is high in the loop diuretics in the urine. Calcium in the urine is low in the thiazide. So urine concentrating ability in loop diuretics is impaired because the loop diuretics, its name says itself, it acts at the thick ascending limb of Henle's loop. So it would impair the countercurrent mechanism because you cannot get the sodium into interstitium very well, so it impairs the concentrating ability. On the other hand, thiazide acts at a different site, so it does not impair the concentrating ability of the urine. they are volume depletion. Loop diuretics, because it's strong action, so it cause more volume depletion. Both of them increase aldosterone release and then cause hypokalemic metabolic alkalosis. Again, next one is if you, let's say, diabetic ketoacidosis, you have ketones excretion in the urine, penicillin hyperate, from toluene, they are not absorbed, so they would bind with A is dose iron, anion, bind with sodium cation, then it would drag it down, so you would lose it in the urine. And then again, because you lose this, you have low volume, stimulate aldosterone, then you would lose the potassium and sodium, and you could develop metabolic acidosis. Yeah, low potassium, lose chloride too. Okay, treatment of hypokalemia depending on the underlying cause, and you would treat that, plus you replace the potassium. When you give potassium IV, be very careful. Do not give more than 20 milliequivalent per hour. If you give higher than this, then the patient develops cardiac arrest. And again, important point, if you have patient with low potassium along with metabolic acidosis, you have to give the potassium, correct it first before you correct metabolic acidosis. Otherwise, you would cause more potassium shift and then muscle weakness, and you can develop respiratory failure. Hyperkalemia, cell shift, the most important. When you have muscle lysis, rhabdomyolysis, tumor lysis, hemolysis, then you would pour huge amount of the potassium because it's in the cell, come out, then you cause hyperkalemia. Drug intoxication, diabetic ketoacidosis, already mentioned, and hypokalemic periodic paralysis because of cell shift. True hypokalemia or pseudo hypokalemia because of when you draw blood. Even though a patient develop, the normal potassium in the blood, but if you draw blood, it's difficult to get. You use a lot of tourniquet, then you would cause, what's that? Okay, you would cause pseudo hypokalemia. Okay, so this is pseudo. So the real one, cell shift, already said that excess potassium intake is rare, but in normal kidney function, it rarely causes hyperkalemia, but it can happen. Impaired renal function or excretion, important. And metabolic, again, metabolic acidosis, cell shift. Only the mineral acid cause cell shift. Organic acid, they don't. But why you see hyperkalemia in diabetic ketoacidosis? Because of the high insulin deficiency. Insulin causes cell shift as well, and also hyperosmolarity. Blood sugar is high, 400-500. Not because of the acidosis. Lactic acidosis, we see a lot of hyperkalemia in lactic acidosis, even though it's organic acid, because of the cell ischemia. Okay, so again, cell potassium shift out of the cell, beta blocker, increase hyperosmolarity, mineral acidosis. Impaired renal excretion, decrease aldosterone activity, so opposite way. And decrease distal sodium delivery, so opposite, everything opposite to the hypokalemia I showed you earlier. And abnormal cortical collecting duct that cause hyperkalemic RTA. Most of the time when you see hyperkalemia in ICU, acute renal failure, most of the time, cell shifts also. When the patient walk into your office, mainly it's chronic. Then you would think about aldosterone problem and cortical collecting duct problem. this EKG changes. You see widening of the QRS complex here. Then this you have to act quickly. Treatment, then you have to give calcium to block effect of potassium on the heart because you don't want the patient to have cardiac arrest. And so that would be number one when you see that EKG. Okay. Then next step, you would give bicarbonate, glucose, insulin to shift it into the cell. Again, important part of cell shift, beta agonist, you can use the inhalers, shift the potassium into the cell, K-exhalate. This is to excrete or remove potassium from the body, but this takes time. So you do all those cell shift first. Next important one is hyper osmolarity disorder of sodium. When you see plasma sodium is controlled in a narrow range because it's important of the cell function. When it changes, either decrease or increase, it causes problem. Either hyponatremia or hypernatremia. Thirst mechanism, when the serum osmolarity changes, thirst is either stimulated or suppressed, and ADH or vasopressin stimulation or suppression, balance between these two, important. Again, plasma or serum osmolarity is maintained in a narrow range, so about 280 to 280, less than 285. So when the serum osmolarity increase into the higher range, then thirst center is stimulated and the vasopressin is stimulated, so that you would want to shift it back down to normal. Thirst would act here. Vasopressin is more sensitive. For hyponatremia, multiple drugs that can cause what we call syndrome of inappropriate ADH release. That's lots of medications. This is the diagram to show you the mechanism of urine dilution. It's important that you understand this. This is the glomerulus. Whatever changes in GFR, then it would reduce the filtrates down here. And whatever acts here at the sodium chloride reabsorption at the Henle's loop and the distal convoluted tubule, let's say diuretics, thiazide diuretics for example, then it would cause disruption of the control of the water excretion, and vasopressin acts here at the collecting duct to allow the water to be reabsorbed. So if the vasopressin disorder, for whatever reason, either appropriate or inappropriate, then you would not be able to do the water handling properly. So then you develop the either hyper or hyponatremia. Okay, so multiple mechanism. So this is syndrome of inappropriate vasopressin release. Cancer, multiple cancer, lung disorder, pneumonia, lung abscess, TB, asthma, pneumothorax, anything in the brain that caused the abnormal vasopressin release as well. So these three main categories cause syndrome of inappropriate ADH and cause hyponatremia. So hyponatremia, how to approach after you understand the basic concept. Assess the volume status is important. So you would, because the pathophysiology is different in these three. Low volume, then the body would respond, increased ADH release, that's appropriate. Okay, so low volume, then many things that would cause the hypovolemia. vomiting or loose through the kidney, then you would see the urine sodium that's low. If it's lost through outside the kidney, then it is low. Same as potassium. Urine sodium is higher if it's loose through the kidney. So that's hypovolemia. Treatment is different. Euvolemia, there's no edema. So most of the time, either cortisol deficiency, hypothyroidism, they're two most common endocrine disorder, stress and SIADH, like I showed you the previous table. Hypervolemia, you would see physical signs of hypervolemia, high jugular venous pressure, peripheral edema, for example, and you can get from history as well. You see urine sodium if it's renal failure or edematous state. You would see nephrotic syndrome, cirrhosis, heart failure. Those has high volume, but could be low urine sodium because you don't have good renal perfusion due to these three disorders. So SIADH, how you would diagnose, you have to exclude other causes like hypothyroidism, cortisol deficiency. And when you see the serum osmolarity is low and the urine concentration or urine osmolarity is inappropriately high, and you have to have normal volume status, okay? And most of the time, patient would have sodium that's high, but not always. And you have to exclude all this. Absence of adrenal, thyroid, pituitary, renal insufficiency, or diuretic use. And most of the time that you will measure the serum uric acid, that would be low because it represents the volume status. Why we have to manage or treat hyponatremia? When patient develop hyponatremia, it means cell edema, and you worry most in the brain that would cause cerebral edema. And this group of patients, they're prone to acute brain edema from hyponatremia. Post-operative, female. Elderly women taking thiazide diuretics. Children, psychogenic polydipsia patient, hypoxic patient, they're prone to develop cerebral edema when they develop hyponatremia. And this patient, alcoholics, malnourished patients, burn victims, elderly women, again with thiazide diuretics, they're prone to develop this complication when you make attempt to correct hyponatremia too quickly. Because when you correct hyponatremia by giving sodium infusion, then you give it too quickly, then you raise the serum sodium too quickly. Then the patient would develop shift of water out of the cell. Then it can cause what this syndrome called demyelinating syndrome. And this can be deadly and irreversible. Have to be very careful when you manage hyponatremia. Okay, this just to demonstrate the adaptation of the brain volume to the hyponatremia. This is normal equilibrium. When you develop acute change in the serum sodium, meaning that the sodium goes down, the cell low sodium or low osmolarity of the ECF volume, then water shift into the cell. So it causes brain swelling, okay? Then when time goes by, a few days or few weeks, brain adapts so that it creates what we call osmotic equilibrium. So then it try to compensate the swelling. So that's why when you have chronic hyponatremia, you don't attempt to correct the sodium too quickly, otherwise you cause problem. And this is the MRI showing that lesion, demyelinating syndrome. develop in the pons, and patient would be quadriplegia. Treatment of the hyponatremia, if they're not symptomatic, mostly chronic, occur over 48 hours, then you don't have to do immediate action. You can take your time to correct the sodium. If it's patient symptomatic, you have to evaluate whether it's acute or chronic. You can get this from the history and many things. If it's acute, less than 2 days, you will probably need to give the hypotonic saline infusion, and you don't raise the serum potassium more than 1 to 2 MEq per hour for acute symptomatic patient. Chronic, you can take your time to correct and do not raise the sodium more than 0.5 MEq per hour or more than 10 to 12 MEq per 24 hours. If you raise it more quickly, than that, then you would develop the problem. Okay, so neurologic disease can follow both the failure to prompt treat and as well as rapid treatment, so you can develop complications either way. Either presence or absence of significant neurological signs must guide treatment. So either patient have neurological complications from the hyponatremia. You have to evaluate that, whether you would decide to treat how quickly. And either acute or chronic of the disturbance impact the rate, how you would correct it, as I show you on the previous slide. Okay, now slide to show the metabolic alkalosis. You lose acid through the stomach by vomiting or NG suction, which you see every day in the patient in the hospital. Diuretics, okay? When you have COPD and have chronic respiratory acidosis, high CO2 in the blood for a long time, and then you put them on the ventilator, then you would wash out that PCO2, right? You ventilate the PCO2 by mechanical ventilation. But you remember this patient, they have compensatory high bicarbonate to begin with, because they would be chronic on long-standing high PCO2, then you have to raise the serum bicarbonate through the kidney. So when you remove the PCO2 quickly by ventilator, or you ventilate them, then you will develop metabolic alkalosis, because the kidney does not have time to adapt. Diarrhea, you can develop metabolic alkalosis in this condition. Villus adenoma, congenital chloride diarrhea. Usually it's rare, but it can cause metabolic alkalosis in diarrhea in this type of patient instead of metabolic acidosis. Alkali source, bicarbonate, of course, lactate, those organic acid that I show you, citrate also, calcium phosphate, calcium supplement phosphate binder, they're calcium containing, and it can potentially cause alkalosis too. So acute renal failure, then you will see this every day also. There are 3 main different types of acute renal failure. Post-renal, you must exclude if there is obstruction of the urinary pathway anywhere, then you don't know about it. Then you would do more harm. You have to do any investigation to exclude the obstruction, because it's correctable and reversible if you do it do it early. Or pre-renal, meaning that whatever caused the low blood flow to the kidney or poor kidney perfusion, it can cause kidney failure. There are multiple etiology, and that's one of the most common. Then now to renal disease in the kidney itself. Okay, either arterial problem, glomerular disease, tubular problem, interstitial part, and intratubular obstruction. Okay, so three main: pre-renal, before kidney, post-kidney, and in the kidney itself. In the kidney, there are multiple structure: blood vessel, glomerulus, tubules, interstitium. So the disease, they're different. In the hospital, you will see a lot of acute tubular necrosis, huge amount. Obstruction also, but acute tubular necrosis, very common. This one, hepatorenal syndrome. Kidney actually functionally abnormal because of the liver failure, but anatomically and morphologically it's okay. So because of the liver disease and chronic liver failure or acute liver failure, then it would lead to all the imbalance of the vasoconstrictor and vasodilator, and in final effect is to reduce the renal blood flow and cause vasoconstriction in the kidney, and it causes renal failure, what we call hepatorenal syndrome. Because when in this patient, if you take out the kidney from this patient with liver failure and you put into a patient with normal liver, then the kidney work normal. So nothing wrong with the kidney, but just the body of the patient with liver failure that has all this imbalance of the vasoconstriction and vasodilatation, causing the abnormal flow to the kidney. And this is acute interstitial nephritis. Lots of medicine, antibiotics, long list, NSAIDs. You know, a lot of medicine cause the interstitial nephritis, almost everything. But which one is more common, then you have to see. Penicillin, methicillin, antibiotics, they're common. NSAIDs also. You have to think about the drug. So history, obtaining from the history. And you will see the manifestation of acute interstitial nephritis. There are allergic reaction to these drugs. Only 25% less than 50% develop rash. So no rash doesn't mean that they don't have it. Eosinophil in the blood, not 100%. Okay, some of them have fever. Urine pyuria, meaning that the white blood cell in the urine. For methicillin, they have more, but other drug, more, we don't use methicillin anymore these days. Other drugs is less than 50%. So you don't see the urine white blood cell or normal urine, you cannot exclude this. So it's just the diagnosis of suspicion. Infectious agent can be the cause of interstitial nephritis too. Viral, parasite, leptospira. You know, leptospirosis is one of the very well-known cause of interstitial nephritis from the leptospira. Okay, now from the tubules and interstitium down to glomerular disease that cause kidney failure. There are 4 different syndromes that point you towards glomerular disease. When would you suspect the patient has glomerular disease? When they have protein urea more than normal. Normal is 150 milligram per day. So if it's higher than normal, the higher the worse. Hematuria along with the protein urea, that's suspicion. Okay, you can develop only macroscopic or microscopic hematuria alone without protein, but most of the time they would go together. Nephrotic syndrome, that's another syndrome with protein in the urine excretion more than 3 grams per day, plus low albumin, hypercholesterolemia. And this one cause acute renal failure. So what we call rapid progressive glomerulonephritis, you will see proteinuria, acute renal failure. You can have hematuria, high blood pressure, and when you see the urine analysis, you would see red cell cast, and kidney failure develop quickly in days and weeks. Chronic glomerulonephritis ongoing for a while. Proteinuria can be anything, renal impairments, and most of the time they have hypertension. And some of them have, when you do the kidney ultrasound, you would see they are small. Kidney is getting smaller, so it's chronic. And there are certain group of disease that causes glomerular disease that cause complement to be low. And so when you measure, you suspect the glomerulonephritis, then you would check the complement level, C3, C4, and when they are low, then you can pinpoint the differential diagnosis to this group of patients. Lupus nephritis, for example, membranoproliferative, post-streptococcal GN, after the strep infection, endocarditis. Membranoproliferative is the type 1, type 2. Okay, so then you would see lupus that you see in SLE, and cryoglobulin is another one that can be associated with hepatitis C infection, which is more common these days. Other causes of nephrotic syndrome, there's long list. Basically, it divided according to the renal pathology, minimal change disease, focal segmental. This is a description of the renal pathology. Most common minimal change is in children, and membranous nephropathy is the most common nephrotic syndrome in adults. That's unknown cause. Okay, this is idiopathic, meaning that we don't really know what caused it. Multiple reasons. Lupus is one, but most common idiopathic nephrotic syndrome in adults is membranous. Most common idiopathic nephrotic syndrome in children is minimal change. Past this. I already said about post-strep and endocarditis. Okay, so proteinuria, it could be related to hematuria or just isolated asymptomatic. When the proteinuria is over 1 gram per day, then that's something to be investigated. Now, hypertension. Normal blood pressure is 120/80. This is GNC 7. Pre-hypertension, above 120 to 139 of systolic blood pressure, from 80 to 89. Stage 1 hypertension is 140/90. Stage 2 is 160/110. Over 100. So again, these days, normal blood pressure is 120/80 or lower. Causes of hypertension, mainly 85% they're idiopathic, or meaning that essential, we don't know, it could be genetic and multiple factors. But in young patients or very old patients, they could be related to vascular problem, chronic kidney disease, endocrine disorder. There's multiple endocrine disorder, Cushing syndrome, pheochromocytoma, thyroid disease, primary hyperaldosteronism, and drug-related as well. So think about secondary cause when they are less than 35 or over 55. So blood pressure lowering agents acts at different parts of the kidney and also cardiovascular system. This is the diagram showing the glomerulus and afferent arteriole and efferent arteriole, and a lot of blood pressure agents that acts at the different parts of the kidney, including ACE inhibitor and ARB. So the study of the blood pressure control and kidney failure. As you know, the hypertension, it has adverse outcome on the brain, meaning that it increased risk of stroke, cardiovascular disease, and any vascular disease, including kidney disease and kidney failure. Is actually one of the most common cause of kidney failure. I think second to diabetes. So we have to attempt to control blood pressure in a good range. When the patient develops kidney disease or they have some indicator of renal involvement from high blood pressure, we would like to keep the blood pressure below about 130. You see this is GFR, this is systolic blood pressure. For kidney, the systolic blood pressure, they're most important. Untreated hypertension, you have the declining of the GFR down here, okay, about 12%. This is bad. When the blood pressure is treated, you would see that the lower the blood pressure, closer to 130 millimeter per mercury, then you would see the reduction of the GFR decline. So it's important to keep the blood pressure, systolic blood pressure, closer to 130 range. And these multiple studies show that you will need at least about 3 medicines to keep the blood pressure in the target systolic blood pressure range. Average about 2.5 to 3 medicines. This is the goal of blood pressure, desirable blood pressure. Type 2 diabetes, less than 130/80, and you prefer ACE inhibitor or ARB. Patient with renal insufficiency, same goal. This is again causes of endocrine hypertension. This would come on your exam. Pituitary problem, Cushing disease, acromegaly, adrenal glands, aldosterone. You know, there are 3 layers of the adrenal glands. Cushing syndrome, aldosterone, and adrenomedulla pheochromocytoma, and thyroid disease, both hyper and hypothyroidism can cause hypertension. Okay, I will go to the kidney stones part. This is chronic renal failure. For the patient who has cystitis, I mentioned briefly about cystitis. Patient present with dysuria and had red blood cell in the urine and lower urinary tract infection. You would have to evaluate whether they have what we call complicated or uncomplicated cystitis. If they have uncomplicated, meaning they don't have any underlying disease, they're healthy, then you give them oral antibiotics for 3 days. Most of the time is the E. coli. Or if they have uncomplicated, but the patient has some kidney disease or prostate problem, which is common in older men. If they're pregnant, then you must treat them 7 days. If they're not pregnant, then you would probably consider give them 7 days as well if they have renal disease and prostate problem. For pregnant women, you probably need at least 7 days. And complicated, meaning that they have an anatomical problem, obstruction, and anything abnormal in the KUB system, or they develop immunocompromised host, then you would want to obtain a urine culture and you just give empirical antibiotics for at least 7 days to cover those potential bacterial infection, mainly the gram-negative. And this show the bacterial etiology of UTIs, gram-negative, common E. coli, 70 to 90%. For uncomplicated, gram-positive can occur as well. For complicated UTI, you have more of the resistant bacteria like Pseudomonas, Enterobacter, Citrobacter, and some gram-positive strep, Enterococcus as well. So you would want to cover this. Briefly about adult polycystic kidney disease, that one of the cause of renal failure. It can cause pain, hematuria, hypertension, and renal failure. So there are cysts, either adult or autosomal dominant polycystic kidney disease, or autosomal recessive, also seen in children, and medullary sponge kidney, not very common. Simple cysts, some of them can turn to cancer. Tuberous sclerosis complex, von Hippel-Lindau can develop cysts as well. This is polycystic kidney. This normal kidney, this polycystic kidney, they are huge. And this is IVP. Okay, last one, kidney stones. 80% are calcium stones, the rest are uric acid, Stroh-White and cystine. Stroh-White, they are related to infection, chronic infection, magnesium, ammonium phosphate. That's composition of the stones. Recurrent rate after first stone. Okay, this is years. This is cumulative recurrence rate. For men, it's higher, but after about 1 year, 15 to 18%, and it's go up higher and higher when the time goes by. So once patient present to you with the first time stone, then you may not have to do any workup. But if they present with recurrent stone, then you need to do something about it. Otherwise, they would recur more and more when the time goes by. Men more than women. These are calcium oxalate in the urine, crystal. Okay, like this calcium oxalate and uric acid crystal in the urine. Cystine, hexagonal, very typical crystal, very typical shape. Stroh-White, so magnesium ammonium phosphate. This also Staghorn calculi. I'm sure you see this a lot. It's huge stone is related to infection, and this is only treated by surgical removal. Again, most common is calcium stone, so we should know what about the calcium stone. Major risk factors for calcium stones: low urine volume, less than 1 liter per day, hypercalciuria, low citrate in the urine, high uric acid in the urine. Dietary factors: high salt intake, high protein intake, low dietary calcium and potassium intake. Oxalate, that's high in the urine. Distal RTA, I showed you earlier, calcium phosphate. Hyperparathyroidism, medullary sponge kidney, which is a genetic disorder. And the low dietary calcium, why that is? In patient who has kidney stone from calcium, we encourage them to take adequate amount of dietary calcium because they bind with the phosphate in the food. It oxalate in the food, so it would reduce the oxalate absorption from the GI tract when you take enough calcium in the food, not the supplement. Multiple studies show that calcium supplement in the pill form, it increases risk of stone. Okay, so so then do not recommend to take the calcium pills, but to take it in the dietary form. That would lower the risk. Protein load, meaning the high protein intake, increase urine stone forming tendency. This is baseline. This is 2 grams per kilo per day of protein in the red. Urine calcium go up, uric acid goes up, and urine citrate goes down. So these all risk factor related to calcium stone. When would we want to evaluate and investigate patients who present with kidney stones? For underlying cause, let's say patient with active stone, meaning they increase it in size of old stones, forming new stones or continue to pass stones. Those are patients with active disease. And the guideline to prevent the new stone formation, again, just remember the first slide with low urine volume, so you have to increase the fluid intake to make the urine at least 2.5 liters per day. So you have to drink at least 3 to 4 liters per day, depending on your the weather and the climate. Thiazide diuretic and low salt intake for patient with calcium stone with hypercalciuria. You can give allopurinol for patient with hyperuricuria, meaning the uric acid excretion high in the urine. Potassium citrate for patient with low citrate in the urine. And for uric acid stones, this depends a lot on urine pH. If urine pH above 6, then you would not form much stones. So you have to make attempt to, besides increase fluid intake, which you need to do in every patient, you have to give to alkalinize the urine with potassium citrate, and you can try allopurinol in some patients with the high uric acid excretion. And cystine stones, very difficult to treat. You need to increase the urine volume and alkalinization of the urine and give some medicine. We don't see that much. Struvite stones require stone removal only. There's no other treatment for struvite stone or Staghorn calculi. Okay, I think that's it.
Well, thank you, Dr. Napisawadee, for the thorough review of the nephrology. Okay. Any question from the audience?
Please ask question. If not, you ask them.ถ้ากรุณาถามไม่มีใครมีคำถาม Go ahead, pick one and ask them question.
No one has any question?
กรุณาถามหน่อยสิฮะคือก็เห็นว่าพวกคนกับผู้หญิงต้องเยอะแยะอยู่มีสปีกเกอร์มอดเรเตอร์ผู้หญิงก็ลองถามหน่อยสิฮะเขาจะได้รู้ว่าเข้าใจสักเท่าไหร่เป็นไง too heavy too fast how much you understand the English half 80% 30%
About half raise the hand. Don't be shy, because we expect you not to understand all of it anyway. I wouldn't if I just in your stage. How many percent understand? Only about half. Raise your hand. How about 80%? 80%? Okay. Oh, that's not bad. How about 40%? Okay. So the rest of it is like 100%, I guess?
Dr. Lisa, would you come here? We can take picture. Dr. we have to fold you. Take picture. ถ่ายรูป